Thank you, ma'am. Good evening, all. I hope you're all doing well. So today's session, today's discussion is on bowel obstruction. So shall I share my screen? I hope it's visible.
Yes, sir.
Yeah, sure. So we'll
Even though
start.
not in presentation mode, it is visible.
Yeah, I'll just change it to slideshow. Okay. So once again, good evening, all. So today's topic is bowel obstruction. So coming to the definition, so bowel obstruction is basically defined as a reduced or absent progress of the forward flow of gastric and intestinal contents through the gastrointestinal tract. So as we all know, usual movement of the food particles or anything through the gastrointestinal system is from mouth towards the anus. So any reduction or absence in the progress of that forward flow, we usually call as bowel obstruction. So although there are many causes of bowel obstruction, today we will be primarily dealing with malignant bowel obstruction or bowel obstruction caused by cancer and some other causes which are cancer treatment related. So coming to the epidemiology, so it is estimated that around 3% to 5% of the cancer patients develop bowel obstruction in their cancer journey. So it can actually occur from anywhere from esophagus all the way down to rectum. Although the most common site is the small bowel. This bowel obstruction is especially common in colon cancer, as we all can expect, because this is actually a bowel cancer. It ranges from 4.4 to 24%, and also very common in ovarian cancer. Ovarian cancer, it ranges from 5.5 to 42%. It is especially common in ovarian cancer, one, because the ovarian cancers can cause some pressure effects on the bowel and cause some obstruction. But more importantly, ovarian cancers have a predisposition to spread to the peritoneum, and it can, the multiple cancer nodules in the peritoneum and mesentery can cause obstruction of the bowel. It can also occur in other cancers, which are not even in the abdomen, through mainly metastasis. Usually, bowel obstruction in an advanced cancer is considered to be a poor prognostic factor. So in an advanced cancer or a patient in a terminal stage or something like that, when the patient develops bowel obstruction, so we usually say that the median survival is around 1 month to 3 months. So it is actually a warning sign, so that we'll be aware that the patient is not very good and something bad can happen at any time. So this is usually considered as a poor prognostic factor, but not always. In an early stage of a cancer, it can actually be tackled through multiple ways, but usually in an advanced disease, it is considered as a poor prognostic factor. So coming to the classification, bowel obstruction can be classified on basis of various things. So mainly it can be classified on the basis of the extent, the site, etiology, and location. So the extent is basically partial versus complete obstruction. It is pretty clear, right? So if the obstruction is complete, uh, for any reason that tumor or mass is completely occluding the lumen of the bowel, it is termed as a complete obstruction. And if the obstruction is partial, which is usually, then it is called a partial obstruction. Usually in cancer, the obstruction is partial. Why? Because for symptoms to develop, the obstruction need not be complete. So even before the obstruction turning into a complete obstruction, the patient may develop symptoms. So at presentation, usually the obstruction is partial, which in turn through the disease process can go into a complete obstruction. But most of the time at presentation, the obstruction is partial rather than complete, because the symptoms develop even before the obstruction is complete. So based on the level, it is again very simple. It can be classified as either single site obstruction or obstruction at multiple sites. Obviously, obstruction at a single site has much better prognosis when compared to obstruction at multiple sites. So third is basically based on the etiology. So based on the etiology, bowel obstruction can be classified as either mechanical or functional. So mechanical is basically when there is a proper block to the flow of the bowel contents. So it's basically like a proper obstruction, like a roadblock. So in the way of the food particles or whatever contents of the bowel, which is moving forward, there is an obstruction which is mechanically blocking the forward flow of the bowel contents. So whereas in functional bowel obstruction, which can also be called as a pseudo obstruction, there is no actual mechanical block per se, but for some reasons, the gut or the bowel is not able to push the bowel contents forward by normal peristaltic activity. So this is the classification between the difference between mechanical, where there is an actual mechanical obstruction, versus a functional bowel obstruction, where there is no mechanical obstruction, but somehow the bowel is not able to push the contents forward. So again, mechanical can be intrinsic as well as extrinsic. So as we is discussed in the previous slide, mechanical obstruction is where there is an actual block to the forward flow of the contents. It can be either that is something inside the bowel, like an intrinsic tumor, a tumor that has developed in the intestinal wall and it is projecting into the lumen and blocking the forward flow of the content. So that is an intrinsic obstruction. Extrinsic is basically something that is outside the bowel. So for example, there can be a mass that is lying outside the bowel, which is compressing the bowel and causing obstruction. Or it can be an adhesion, especially post-surgery, where there is an abnormal connection between two organs, like bowel and some adjacent organs, around which the bowel can twist, kink, etc., which can cause an obstruction. So it can be either intrinsic or extrinsic. So coming to the functional bowel obstruction. So as we already discussed, there is no actual block as such, but somehow the bowel is not able to push the contents forward. So it can be some neuropathies, especially in cancer, there can be some paraneoplastic neuropathies, which can actually affect the ability of the bowel to undergo peristalsis and push the contents forward. It can also be a tumor that is infiltrating into the bowel and destroying the nervous plexus there, again causing some functional obstruction, especially common in paraplegic. So paraplegia again is common in cancer, because there can be some metastasis to the vertebral bodies, which can cause some compression on the spinal cord. Paraplegics also, it is common. Another cause would be metabolic. So as we all know, so hypokalemia, hypomagnesemia, all those things can cause paralytic ileus and can cause functional bowel obstruction. Another important drug example for functional bowel obstruction, especially in the scenario of cancer, would be some drugs. So one of the most important drugs that we use, especially in palliative care, is morphine. When it is not paired with stimulant laxative, it can cause ileus. Because when we give oral morphine, it goes and attaches to the opioid receptors in the bowel, which reduces the peristaltic activity of the bowel, which can lead to functional bowel obstruction. So again, another classification would be based on the location. So we have seen extent and all those things. Another classification would be based on location. So it can be either upper GI or lower GI. So typically we classify upper GI as stomach, esophagus, and duodenum, and the rest of the gut is usually taken as lower GI. So based on the location, it can be upper GI obstruction or lower GI obstruction. The importance is the symptoms actually varies between upper GI obstruction and lower GI obstruction. So coming to the pathophysiology. So this is basically to understand the pathophysiology of bowel obstruction, we can just think of a simple example of a clogged sink. So whenever we have a clogged sink, whenever kitchen sink is blocked, so what we usually do, so we do something to push that forward, right? And again, we'll flush it with water. So it is almost the same thing that is happening here. So whenever there is an obstruction in the bowel, so there will be accumulation of contents proximal to the obstruction, which will cause proximal distension of the bowel. The bowel will get distended. This distension activates various mechanisms in the bowel, and which will result in increased peristalsis and increased secretions. So basically what happens is whenever there is a distension, the bowel will try to push harder so that the contents will go forward. And again, as I mentioned earlier, so the next natural response would be to flush it. So to flush it, there will be increased secretion. There will be activation of vasoactive intestinal polypeptide or VIP. There will be increased sodium and water secretion and reduced sodium and water absorption. And finally, what happens is the gut will try to push it harder so that it bypasses that obstruction, and again there will be increased secretion. So, but if for some reason that is not successful and the obstruction is not allowing the particles to pass through, there will be accumulation of contents. So accumulation of contents will again result in distension. It will again result in increase. So this continues as a vicious cycle. So at this point of time, the most important symptoms would be pain. mostly colicky pain because the bowel will be continuously contracting against the resistance. So it will cause some pain. There will be bloating. Why there is bloating? Because there is accumulation of contents. So whenever there is accumulation of contents anywhere in the body, there will be bacterial overgrowth. The bacterial overgrowth will produce gas, which will again increase the distension. So there is a sensation of bloating and nausea. So if the obstruction is in the upper GI, if the gut cannot push the food particles forward, the next way of managing the obstruction would be to take it backwards to the mouth. So there will be sensations of nausea and vomiting. So this is actually the first stage of obstruction. So after some time, what happens is, so this obstruction is not going away, the distension is again happening. So the bowel keeps on distending and distending. Contents gets accumulated and accumulated. What happens is there will be inflammation, local inflammation of the bowel. So local inflammation of the bowel will cause edema. So whenever there is inflammation, you know that there will be edema. So there will be bowel edema. So already there is an obstruction. Now, if the bowel becomes edematous, the obstruction will again increase. So it will again goes to increased distension, and this cycle will again go on. So this will go on for some time. So after some time, what happens is the bowel will keep on dilating, and finally, so there will be decreased blood supply. So there is a block, the bowel will get distended, the blood flow to that particular part will be reduced, and finally it will result in bowel ischemia. So once that happens, what happens is the bowel is ischemic, the bowel is very much distended. So there won't be much peristalsis because the bowel is hugely distended and ischemic. So then in later stages, it can go into perforation, peritonitis, sepsis, multi-organ dysfunction, etc. So in this stage, since the bowel is very much distended and there is not much peristalsis, the main symptom will not be colicky pain, which will be usually abdominal distension. So initially, we have seen that the initial symptoms would be colicky pain, nausea, vomiting, etc. So those are body's attempts to push the contents forward or push the contents backward and take it out through vomitus. But in this stage, since the bowel has become hypoactive, the main symptoms would be distension and other symptoms other than colicky pain. So I think the pathophysiology is clear. So coming to the signs and symptoms. So signs and symptoms again actually varies between varies according to the site of obstruction. So we have seen that we can divide the bowel obstruction into upper GI obstruction and lower GI obstruction. The symptoms also actually varies between that. For example, let us take an obstruction here in the gastric outlet. So what happens is, see, there are two options. If there is an obstruction, so the bowel can actually try to push it downwards beyond that obstruction, or it can actually take it backwards and take it out through the mouth. So I think in this particular position, which one would be easier? Can anyone of you tell me? So which is logical? So pushing it all the way through the 22 feet of small intestine, large intestine, and downwards, or just take it out through the mouth and take it out. So which one will be easier? Anybody unmute and tell me? Yeah. So obviously vomiting would be easier because see, and again, so you know that there is something called retropulsion, a reverse peristalsis, right? So it is basically the vomiting reflex, and it usually happens in the upper GI. Vomiting usually happens in the upper GI. So whenever there is an obstruction in the upper GI, the primary response of the body would be to cause a reverse peristalsis and take it outside. So in other words, whenever there is an upper GI obstruction, the symptoms would be much earlier when compared to the lower GI. So you can see that when this is just stomach, if there is an obstruction here, whenever the food actually fills the stomach cavity and whenever there is an obstruction, the patient will immediately vomit out, right? So since vomiting is much common, so the patient tends to present early. So in comparison, just take a look at here. So this is the large bowel. So it is somewhere in the descending column. So if there is an obstruction here, so which is the easiest way? Which is the easiest way for the body to try? To push it downwards or push it backwards all the way through the small bowel into the stomach and into the mouth? Which will be easier? Yeah, exactly. It will be downwards, right? So this is the natural phenomenon. So whenever there is a gastric upset, so we all know, right? So whenever there is some gastritis, what will be the primary response? You'll just vomit it out, right? So for example, if you go to a party and you eat too much, your stomach is very full. So what do you usually do? You go to the bathroom or just put a finger in your mouth and vomit? We usually do the later, right? We just put a finger in our mouth and vomit, then we'll feel all better. So in contrast, when we have a lower abdominal pain, there is a cramping lower abdominal pain we usually get in some gastrointestinal infections or acute gastroenteritis or whatever. So if we have a crampy lower abdominal pain, do we usually go to the bathroom or we'll just try to vomit out? We usually go to the bathroom, right? So this is same. So whenever there is an obstruction downwards, the body will try to push it. And if for the vomiting to occur, so it has to go, the food have to fill here, and it has to go, that content, that obstruction will have to be a long-standing one, and the contents will have to fill here the entire colon and go back to the intestine. When there is once it reaches the small intestine, that vomiting reflex is actually developed. So it will take a long time to become for the obstruction to become this much, because as I told you, it will not be a complete obstruction always. There may be some small opening for the contents to go through. So there may be increased secretion, and some of the stools may seep in as a spurious diarrhea whenever there is an obstruction. So some of the contents may be seeping down. So it will take a long time to actually for the contents to actually accumulate here and go up to all the way up to the small intestine. So this particularly actually presents as some colicky lower abdominal pain, which is usually mild, and because the colic is also not severe because it has a lot of space here to fill it up, right? So, and it primarily presents as constipation here. So what happens here is the primary symptom would be vomiting. So which will you take seriously, constipation or vomiting? So usually vomiting, right? So the patient usually presents early. And one more thing is, see, one more thing would be the signs, whatever that we can find through the clinical findings. So since the vomiting is very common here, so whenever there is an obstruction in the upper GI tract, suppose in the stomach, once the patient vomits out, there won't be any clinical signs for you to appreciate, right? See, in contrast, there is a lower intestinal obstruction. So there will be a lot of accumulation here before something happens. So when you palpate, there can be like a dilated bowel loop or a visible peristalsis. All those things can be there. But in case of a CA stomach, there can be a palpable mass which can be palpated per abdomen. But other than that, once the patient vomits out, the bowel will go back to its previous state, and there is nothing much that we can identify which is in relation to the obstruction in the upper GI. But in lower GI, there may be some definite findings because there may be some dilated bowel loops, some contents that you can palpate with the abdomen, etc. So this is the difference between upper GI and lower GI obstruction. Yeah, so this is like a symptom, just that what we have discussed in the previous slide. So basically pain in the proximal GI obstruction, it can be usually upper because the site of obstruction is in the upper GI. So it can be upper or towards the central abdominal region. It is usually seen as a colic. In distal GI, it is usually in the central to lower abdomen. The colic is usually towards the central and lower abdomen. Vomiting is usually early and very severe, as we mentioned. Distal GI, it is usually late and less severe. And distension is usually absent because once the patient vomits out, there is nothing in the bowel, so the bowel will be normal. There won't be much distension. Distal GI, the distension is present because the contents are not going anywhere. It's just keep on accumulating. It is not going downwards. It is not going upwards. So there will be significant distension in the distal GI obstruction. Constipation, proximal GI will be less because whatever obstruction is there, we are vomiting it out. Distal GI, it is usually more because usually the presenting symptom would be constipation. I think it is clear. So coming to the clinical evaluation. So coming to the history. So when a patient comes to you with suspected bowel obstruction, suppose the symptom is constipation. So the first question you should ask is, are you passing gas? So this will give us an idea whether the obstruction is complete or partial. So if the patient is not passing gas, in other words, if he or she is having an obstipation, it is an indication that the obstruction is usually complete. But if the patient is passing flatus and if there is a constipation, so it can be because of any incomplete or partial obstruction. So if there is vomiting, we can actually ask about the timing, contents, and smell of vomiting. So timing will actually give us an idea about the site of obstruction. If the site of obstruction is all the way up in the esophagus, the vomiting would be immediately after the food intake. So as the site of obstruction comes down and down, the more delay is there from food intake and vomiting. So if it is in the stomach, it may take some more time to be vomited out. If it is lower down in the intestine, it will take some more time. So timing actually gives us an idea about the site of obstruction. Second would be contents. So see, if there is something in the esophagus, it will be the vomitus would contain undigested food particles. If it's in the stomach, there may be some acidic vomiting. So if that is down in the intestine, it may be bilious vomiting. So the contents will actually help us identify the site of obstruction. And if there is a severe lower GI obstruction finally ending up in vomiting, there may be some fecal contents also in the vomiting. Smell of vomiting, again, if the vomitus smell feculent, so we can assume that the obstruction is usually lower down. So that is usually in the history. So I'm not discussing the entire history here. So these are some of the salient points that we should definitely ask when dealing with a suspected obstruction. The second thing would be examination. So the findings you can actually make out in examination is basically abdominal distension. So that usually happens in lower GI obstruction, because in upper GI obstruction, once they vomit out, there won't be much distension. And visible gastric or intestinal peristalsis, because basically what happens is in the early stage, as we discussed, the bowel is trying to push against the resistance. So we can actually see the exaggerated peristalsis through the abdomen, either gastric or intestinal. So always check for bowel sounds. One thing that I want to stress is we should always check for bowel sounds. And bowel sounds also actually can vary according to the stage of the obstruction. As I mentioned, in the early stages of obstruction, the bowel is hyperactive and you can actually appreciate increased bowel sounds. So in the later stages of mechanical obstruction, the bowel is hypoactive and the bowel sounds may reduce. And again, in functional bowel obstruction, where the capacity of bowel to push the contents forward is reduced, so it is basically a hypoactive bowel, right? So there may be decreased bowel sounds there. So per rectal exam. So this is one important thing. So one thing is actually, it can actually help you differentiate between a constipation and a bowel obstruction. If there is some hard fecal mass in the rectal, in the per rectal examination, there is some impacted feces there. So you can see that it may be a constipation also. Then you can try an enema or digital rectal evacuation, etc. And then usually in bowel obstruction, the rectum will be empty. So that again will give us an idea. The patient has not passed stools for 4 or 5 days. And when you're doing a PR examination, there is no fecal matter there. So what you can assume is that, infer is that the bowel content for the fecal matter is not reaching the rectum. So it can be a sign of bowel obstruction. So per rectal examination is one important thing. So signs of dehydration is something that you should look to. So if the patient is very dehydrated, otherwise good patient who is very dehydrated, we can always help him with some IV fluids or something like that. So that will be again based on the condition of the patient, that will again discuss later. So coming to the investigation. So one thing that we can do, so basically in palliative care, the idea of all investigation would be, so if you're doing an investigation, you should do something about it. So even if you're doing something, if you're doing an investigation and if you're not planning to do anything by, so if you just want to check particular electrolyte status, sodium, and if you can't correct sodium, so there is no point in doing that. Same thing. So that is for all investigation. Don't test something unless you can correct it. So electrolytes, obviously we can check, because see, it can be of two things. So if there is increased vomiting, so there may be some metabolic alkalosis because of increased loss of gastric acid. So even the lower GI obstruction, there may be some other electrolyte imbalances and all those things, something that can be correctable in an otherwise good patient. So that is one investigation you can consider. The other parameters are normal. The patient is otherwise healthy, suddenly presenting with a bowel obstruction, and cancer treatment was generally going well. So then definitely electrolytes is one test that you can. Imaging wise, see, the one thing that you can usually use to confirm the bowel obstruction would be an X-ray. It is very easy to do. It is almost universally available. One thing to keep in mind is that X-ray should be erect. The X-ray of the abdomen should be erect, should not be in a supine position. So what you can appreciate is some air fluid level. So this is some advanced obstruction. So what happens is basically the bowel will become grossly dilated. The bowel is not at all moving. So what happens is the fluid actually collects here like a bowl. What happens is whatever air is there, it will actually collect on top of the fluid. So it will have an air fluid level. So this multiple air fluid levels here, which is one sign of intestinal bowel obstruction. So you can confirm an X-ray, confirm an obstruction with an X-ray, but if you need to find the cause of the obstruction, X-ray is not sufficient. So again, then if you are particular about finding the cause of an obstruction, a CT scan would be the investigation of choice. So whether should you find the cause of obstruction is another question altogether, because in a very sick patient, a terminal patient, So even if you find the cause of obstruction, there may not be nothing much you can do about that particular cause. But if that is a young patient, good malignancy with a good prognosis, he is responding to treatment well. So you want to know the cause of the bowel obstruction, that so that you can do something about it. So the investigation of choice would be a CT, which has a 93% sensitivity and 100% specificity in finding out the cause of bowel obstruction. So this is the previous slide. So coming to the coming to the management. So basically, in palliative care, for all symptoms, the management will consider of three principles. One will be correct the correctable. So whatever correctable cause is there, you can correct. Second thing would be non-pharmacological measures. Third thing would be symptomatic drug treatment. So this is a universal protocol that we use for all symptoms in palliative care. So coming to the non-pharmacological measures. See, these are the three things that we usually do in palliative care. So correct the correctable, non-pharmacological measures, and symptomatic drug treatment. So basically, whenever we are managing a bowel obstruction, the guiding principles that will help us manage the bowel obstruction would be level of obstruction, disease status and prognosis, and performance status. So these are the things that we should keep in mind before going to the management of bowel obstruction. See, the thing is, if you ask me what is the gold standard for treatment of bowel obstruction, I would say surgery. So that is the only definitive way to treat bowel obstruction. So surgical measures can be resection. So if there is a segment of bowel that is obstructed, which can be resected out, and the other two portions of the bowel can be sewed in together, that is one option. Second thing would be bypass. So for some reason, the cause of that obstruction, the particular segment of the bowel which is obstructed, cannot be resected out because it may be adherent to some of the adjacent structures and all those things. It cannot be resected out. Then we can do is what we can do is a bypass. So basically like gastrointestinal and all those things. That is called a bypass. Stoma is basically you actually cannot resect the cause of the obstruction. You just close it and bring the proximal bowel outside as a stoma and keep a bag there so that the fecal matter can pass out. So these are the main three surgical measures. And there are also some palliative measures like gastric venting. So what happens is, see, palliative gastric venting is whenever there is a severe upper GI obstruction and the stomach is completely inflated and it is causing great vomiting and all those things. You just put a tube in to the stomach, not through the mouth, through like a gastrostomy, venting gastrostomy, so that the contents can be drained and the obstruction is relieved. The symptoms of obstructions are relieved. So that is gastric venting. And there are options of self-expanding metallic stents to prevent an obstruction. So these are the palliative methods of managing surgical management of bowel obstruction. So to decide on whether to give a patient surgical options for bowel obstruction, there are some poor surgical prognostic factors in patients. So this would be advanced stage. So if a patient is very elderly, he is unlikely to tolerate the surgery. Poor prognosis. If the patient is terminal and he is going to die soon, we don't expect a long survival. The disease status is poor. So then we don't need to go for a surgery because it won't make any difference, right? Then ascites is another actually very poor prognostic factor, because usually in ascites, if we open the bowel, it will be very difficult to do the surgery and want the wound to heal. So that is a very poor prognostic factor. And previous radiotherapy. And one more thing about ascites is, so ascites, if the patient has a malignant ascites, that means that if there are some malignant cells in the ascitic fluid, it basically means that it has spread all over the peritoneum, because those cancer cells can go and seed on anywhere in that peritoneal cavity and they can grow and cause a new obstruction. So ascites is one poor prognostic factor. So previous radiotherapy to abdomen. So if you give a radiation to the abdomen, what happens is there is some post-radiation changes. The tissues can go in for fibrosis, there can be some adhesions and all those things. In those cases, surgery may be difficult. Again, previous cancer surgery, as you can see, the cancer surgeries are usually extensive. So if there is a previous resection there, again, some adhesions, post-surgical adhesions may be there. It may be difficult to tackle. And multiple sites of obstruction. So usually if there is one site, we can think about surgical things. So multiple site means it will be difficult, because even if we take out one, resolves the obstruction on one side, another site is already present. Poor performance status. If the patient has a very poor general condition, he may not be able to tolerate the surgery. So who are the candidates for surgery? Especially a patient with a single obstruction. The obstruction is only on one particular site, and he is responding well to anti-cancer treatment. he's having a localized disease. So basically cancer can be either localized or metastatic. So if the cancer is only limited to that particular region, it has not spread to anywhere else. In that case, we can actually try surgical options. Young patients with good performance status, and again, benign causes of obstruction. So as I mentioned earlier, all obstructions in cancer need not be due to cancer. For example, if a patient has undergone a radical cancer surgery, and even if the patient is completely cured, he or she can develop obstruction as a result of adhesions which can occur after surgery. So benign cause of obstruction, definitely surgery is an option. So these are the correctable things. So coming to the non-pharmacological measures that we can actually do for bowel obstruction. This would be the surgical options. Non-pharmacological measures would be, first thing, some of the obstruction usually gets better when we rest the gut. So if you actually reduce the intake for 1 or 2 days, just keep the bowel rested. Just give sips of fluid. So some people may have vomiting even with sips of fluid. In that case, we can ask them to suck ice or give some lemon juice or something to wet the mouth. So if you rest the gut for 1 or 2 days, in some cases, obstruction usually relieves on its own. So during those times, you can support the patient with IV fluids. And again, IV and subcutaneous hydration can be an option that particular time. But again, if the patient is terminal, nearing its death, hydrating the patient may not be beneficial. But if it's a young patient, as you mentioned earlier, single site of obstruction, and we are expecting a good prognosis, definitely hydration is an option. So whether to keep an NG tube is nasogastric tube is another option. So the idea of keeping an NG tube in a bowel obstruction, especially, will be to decompress the stomach. See, the thing is, as I mentioned earlier, so decompressing the stomach will only work in upper GI obstruction, right? So how far the NG tube can go, it can actually go into the duodenum, so not beyond that, right? So those things, NG tube will only work if the obstruction is upper GI. So if there is a lower GI obstruction, there is no point in putting an NG tube because the stomach will not be full with contents. Right. So, and again, in all cases of upper GI obstruction, we need not put an NG tube. We usually reserve NG tube with high volume of vomitus multiple times a day. If the patient is having significant distress, in that case, we put in an NG tube. So otherwise, we'll just rest the gut. So another option is called an NJ tube. It's a nasojejunal tube. So this can be actually a viable option, especially as a palliative measure. So whenever there is a gastric outlet obstruction or upper intestinal obstruction, what we can do is, if a tube can be negotiated through that opening, we can put in a nasojejunal tube. So what that will do is it will go straight away into the jejunum. So we can actually feed through the tube like we do in an NG feed. So what happens is, even when the disease progresses and the obstruction becomes complete, so that tube will remain there, which can act as a way of feeding and giving medications for that patient. So NJ tube is something that we can consider as feeding measure. So NG tube's idea would be, in a bowel obstruction, would be to decompress the bowel, not as a feeding measure. NJ tube or nasojejunal tube can be a feeding measure when there is an upper GI obstruction. So I think that is clear. So we have mentioned the correctable, so surgical options and non-pharmacological options. Now we are coming to the pharmacological measures. So see, basically, the group of drugs that we use for bowel obstruction can be classified as those which facilitate gastric emptying or which relieve the obstruction. So prevent secretions or prevent worsening of the obstruction, and treat associated symptoms. So these are the three classes of drugs: those which facilitate gastric emptying, those which prevent secretions, and those which treat associated symptoms. These are the three groups of drugs that we usually use. So in the, as I mentioned, in partial obstruction, so what we are usually trying to do is, we try to push the foot forward, so that partial obstruction, so that symptoms of obstructions are relieved. So in complete obstruction, there is no point in pushing again. So then what we are trying to do is, we'll try to prevent the secretion, so that obstruction or that accumulation of fluid is not worsened. That is the second class of drugs. So there may be associated symptoms with that. Analgesics and antiemetics can be used to treat those symptoms, like vomiting or pain can be there. Those can be used for that. So see, we'll go to the first class of drugs. So first class of drugs would be those which facilitate gastric emptying, which includes steroids and prokinetics. So steroids, the usual steroid that we uses dexamethasone. So what steroids do is, it reduces the peritumor edema. So universally, whenever there is a tumor, there would be some surrounding edema. And as I mentioned earlier, in bowel obstruction, after some point of time, there may be some inflammation in the bowel also. There may be some bowel edema also. So what steroids will do is, which will actually reduce the inflammation and bring down the edema. So when the tumor edema decreases, the tumor may shrink. And when the bowel edema decreases, the bowel may become more patent. So we can try steroids. And as I mentioned, most of the obstructions that we come across in cancer at presentation are partial and not complete. Because see, as I mentioned earlier, an obstruction need not be complete to produce symptoms. Even a partial obstruction, which is very close to being complete, can produce symptoms. So keeping that in mind, so we can actually try giving dexamethasone with the hope that it will reduce the tumor edema and the bowel edema and make the bowel more patent so that the stool or bowel contents can pass through. Usual dose is 8 to 16 milligram per day, and we can give a trial of 3 days. We usually give it as a twice daily dose in the morning and around 2 to 3 p.m. because usually there is a tendency to give steroids thrice daily, but usually when given steroids in the night, some people have some sleep disturbances. So in palliative care, we generally give steroids 2 times a day, morning and around 2 or 3 in the afternoon. So if it improves after 3 days, so this thing would be subcutaneous because the patient is not able to take anything orally. So if the condition improves and the patient starts taking orally, then we can change the steroids to the oral route. And one more thing, especially important with steroids, whenever you are prescribing oral steroids or steroids in general, always give some gastro protection because gastric contents, steroids has a tendency to produce gastric ulcer, to damage the gastric membrane and produce gastric ulcer, which is especially important in this case because we are resting the gut, we are not giving anything to the patient, so there may be some increased secretions also. So we usually, generally in other cases, we give proton pump inhibitors with steroid for gastro protection because they are more powerful. So in this case of obstruction, H2 blockers like ranitidine or famotidine can be better because in addition to the gastroprotective effect, H2 blockers has an antihistaminic action which will reduce the secretions of the bowel. So it has a double advantage in this condition. So in this particular scenario, rather than a proton pump inhibitor like pantoprazole along with steroid, H2 blockers may be more beneficial because it has an anti-secretory effect as well. So the next thing would be, along with steroids, would be to give prokinetic. So if you give steroids for some days and then we can try a prokinetic. So prokinetic, basically what it does is it will actually increase the bowel peristalsis. So we are actually trying to push the content. So technically in a complete obstruction, if you give prokinetics, there is a chance of bowel going into perforation because already there is an obstruction and you are actually trying to push the bowel harder. It may go for perforation, but it is usually not seen in practice because most of the obstructions are, as I mentioned earlier, are partial. So prokinetics can be tried. So the usual prokinetic that we try is metoclopramide. So the dose is also a little bit higher than we usually. The usual dose of metoclopramide that we give is like 10 mg TID, right? 3 times a day. So we usually start with double the dose. You can actually start with 10 mg Q8 hourly, and many cases we are actually starting with double the dose. We can actually go up to a total of 120 milligram per 24 hours. So the recommendation would be to start with 10 mg 3 times a day and then actually increase the dose day by day. We often start with 20 milligram 3 times a day also. That is also being done. Only thing is we have to actually be beware of increase in colic. So if the patient is having increased colicky pain, abdominal pain, then we have to immediately stop the prokinetic. That means that the obstruction is complete and it is actually causing more damage. If obstruction is not relieved, don't just keep on giving the prokinetic. We have to stop after 1 or 2 days if the obstruction is not relieved or the colic is increasing. And only initiate prokinetics in a patient with obstruction if you can monitor the patient, because you have to continuously monitor for increase in colic and abdominal pain. Okay, so that will be about prokinetics. So if you try prokinetic and steroids for 2 or 3 days, and if the obstruction is not relieving, so it points to a complete obstruction. So once we establish that there is a complete obstruction, there is no point in trying to relieve the obstruction or push the contents forward. So now actually our aim would be to reduce the accumulation of secretions there so that the patients will have lesser symptoms. So the idea would be now the next class of drugs comes into play. anti-secretory agent. So what we are trying to do is we are trying to reduce the bowel secretion so that the amount of fluid collected there is less and the symptoms for the patient is also less. So the drugs we usually use is hyoscine butyl bromide, which is an anticholinergic. The dose usually given is 40 to 120 milligram per day subcutaneously. See, whenever there is a bowel obstruction, it is ideal to give all these drugs as a continuous subcutaneous infusion. We need not be IV, continuous subcutaneous infusion. So the idea would be to provide a continuous flow of drugs. The patient will have a smoother symptom relief. It can also be given as divided doses, but ideal would be to give us continuous subcutaneous injection. Hyoscine butyl bromide, we can actually go up to 120 milligram per day. And next would be somatostatin analogs like octreotide. So octreotide will decrease the secretion, decrease the motility, and decrease planktonic circulation, the circulation to the bowel, and thereby reducing the blood flow and reducing the secretion. So it has a multitude of effects, which is all beneficial in a complete obstruction. So it reduces the motility also, so the pain will be less. And especially it is not used for all patients, especially used in large volume vomiters, which is not refractory, which is refractory to all other measures. The usual dose would be 100 to 600 microgram per day, again as a continuous subcutaneous infusion. So H2 blockers like ranitidine, as we mentioned earlier, can be used for gastroprotection as well as anti-secretory action. So next thing would be associated drugs. So as I mentioned earlier, this is anti-secretory agents. So now the next option would be to treat associated symptoms. The usual associated symptoms would be pain and vomiting. So analgesia can be of two types. So there can be a background pain. See, the thing is, the patient may have pain even before the obstruction because of the cancer infiltrating in the adjacent tissue in the bowel. So also, the obstruction may not be because of a bowel cancer. It can be because of a metastatic deposit from a cancer somewhere else. So in that case, the patient can have pain in that particular region also. So many of the patients would have been on opioids before the obstruction happens. So we should not stop the opioids, because they have to continue that so that the other pain, the pain that is already present for the patient, is taken care of. The route of the opioid, though, is very important. So previously, we usually, we are all aware about the WHO pain ladder, right? Through the mouth, through the ladder, through the clock, around the clock, you all know that. So we usually prefer oral route, but in this case, if the patient develops an obstruction, in complete obstruction, the patient is not taking anything, and even in partial obstruction, so opioids, as I mentioned earlier, is a cause of functional bowel obstruction. So oral opioids can go and attach to the opioid receptors in the intestine or bowel and can reduce peristalsis. So in case of a partial obstruction, if you are trying to push the contents outwards, oral opioids may actually worsen that obstruction. So usually we avoid oral opioids, even when the obstruction is partial. In a complete obstruction, obviously we cannot give it orally, then we can give it either IV or subcutaneous. So if that is not possible, another option would be to go for a fentanyl or a buprenorphine patch. Like if morphine is cannot be given, because if a patient is being taken care at home, we cannot actually give injection morphine to the patient and ask them to take it subcutaneously. We can give other medicines, but not injection. In that case, we can use a patch also. So another strong opioid. So the route would be parenteral, not oral. That is the only thing. The second type of pain would be abdominal colic. So especially in the early stages of obstruction, the cause of pain would be the bowel contracting against an obstruction. So abdominal colic, again, the drug of choice will be hyoscine butyl bromide, 40 to 120 milligram per 24 hours. See, the one thing about hyoscine butyl bromide is don't ever give it along with the prokinetic. So what we are trying to do with the prokinetic is increase the peristalsis and then push the contents forward. Anticholinergics, what they will do is decrease the peristalsis and decrease the secretion. So if we give both of them together, we are actually failing our own purpose. So don't give them together. Either anticholinergics or prokinetic agents can be given. So that is about analgesia. So again, the next symptom would be vomiting. So you can give antiemetics. Like one thing would be prokinetics. So if it's a partial obstruction, it should not be given in complete obstruction, prokinetics. Again, keep that in mind. Second thing, one important antiemetic would be haloperidol. Haloperidol, especially when patients have persistent nausea, it is a very effective drug. It can be given as either a continuous subcutaneous infusion or as a SOS or TID or something like that. So the usual dose would be 2.5 milligram to 10 milligram in 24 hours. So another thing that you would be very familiar with is 5-HT3 antagonist, ondansetron, right? So what happens is whenever there is a bowel distension, there is secretion of 5-HT3 or serotonin. So in that case, ondansetron is also a useful antiemetic when there is a bowel obstruction. So again, ondansetron actually slows down the peristalsis. So in a partial obstruction, if you are trying to actually push the contents forward, prokinetics would be a better choice. But in complete obstruction, haloperidol or ondansetron would be a better choice of antiemetic. So that brings us to the end of our presentation. So I have taken 5 minutes extra. Sorry about that. So now actually I think we can go for any questions if there are any.
Thank you, Dr. Jewell, for that elaborate presentation. I believe at least some of the participants might be having queries or their inputs. We are opening the forum for discussion right now before we move on to the case presentation.
You can either ask or put up in the chat box. So if that is something that I can answer now, I'll just try to answer it. So if something that I don't know comes up, I'll definitely refer and actually get back to you through the Italian India team. So please feel free.
Excuse me, sir.
Yeah, please, ma'am.
Sir, usually if we are using morphine on a routine basis,
Yes.
patients tend to develop vomiting even in lower doses.
Yes.
So in that case, how should we go? Should we switch over to another opioid?
Yeah. So yeah, that is actually a very important question, ma'am. So the thing is, usually two things to consider here. One thing is opioid-induced nausea and vomiting is usually self-limited. In most of the cases, opioid-induced nausea and vomiting actually settles in 3 to 5 days. That is the first point. Second thing, for the same reason, whenever we are giving opioids, we always should give prophylactic antiemetics. So these are the two reasons. So if there is intractable vomiting even after a week of starting opioids, you should actually look into another reasons, because usually the nausea and vomiting caused by opioids will be settled in 3 to 5 days. And usually whenever we prescribe a strong opioid, we should always co-prescribe and prescribe along with it a prophylactic antiemetic. So usually we prescribe prokinetic agent because it will actually be helpful for the constipation caused by morphine also. So that is what we are doing. So if the nausea and vomiting persists after a week, so you should actually look into another causes. And if for some reasons the patient is absolutely intolerant to morphine for some reason, there is an option to change to another strong opioid like a buprenorphine patch or a fentanyl. It is actually less emetogenic compared to morphine, but usually that is not required because the nausea and vomiting is usually self-limited, and prophylactic antiemetics usually helps in controlling the nausea and vomiting.
And is it dose related? Like, is it more likely to occur at higher doses and less likely to occur at lesser doses?
No, usually all patients when newly initiated on morphine will have some vomiting. Okay. Irrespective of the dose, even in smaller doses, they can have vomiting. So prophylactic antiemetics is a must with all doses.
But I have seen in my personal experience that in spite of giving antiemetics, the sensation of nausea remains. It doesn't go completely.
Okay, so if you feel that for some reason the patient is having persistent intolerance to morphine, another option to consider is other strong opioids like fentanyl or buprenorphine. If the patient can afford that, which will have actually less emetogenic potential when compared to morphine.
Okay, thanks.
How to give opioid continuous subcutaneous infusion. So actually, basically, you can actually put a subcutaneous needle and just the easier option would be to give an infusion pump so that you can actually monitor the thing. So you can also give it as see, the thing is, infusion pumps are not available everywhere. So the place where I did my PG, we had infusion pumps only in the chemotherapy unit. So what we did was we just we count the drops. So that is what we usually do. And one more important thing is with subcutaneous infusion, you will not be able to use large volumes of fluid like we do in IV infusion. So the thing is, basically you mix octreotide in a particular amount of saline and then give it and actually monitor the amount of octreotide that is going. So the total dose would be 100 to 600 microgram per day. And we don't usually give octreotide subcutaneous infusion because one, it is costly and it is not usually practiced, only in cases of intractable vomiting with very large volume vomiters and high patient distress and all those things.
Any other quick questions or queries or inputs we can take in, or shall we move to the previous? Dr. Bhatti? Dr. Bhatti, am I audible?
Yes, ma'am.
Do we have Dr. Bhatti here?
Hello, am I
Yes, sir.
audible, ma'am?
Yes,
Yes,
sir. Please continue.
Yes. So, can we start, ma'am?
Yes, sir.
Definitely. Yes.
Ma'am, is my screen is visible or?
Yes,
We are
please,
sharing
Dr.
the
Mohit, your
Oh,
screen is
oh.
visible.
Okay. Ma'am. So, good evening, everyone. Myself, Dr. Mohit. Today, I am presenting a case history. A 24-year female patient whose diagnosed with the recurrent primitive neuroectodermal tumor, anterior abdominal wall. The patient is a post-surgery, post-chemotherapy, and she was in advanced stage. So main presenting complaints at the time of admission was the breathlessness for 2 days and distension of abdomen for 5 days. The history of present illness: the patient got incidentally diagnosed of left adnexal mass in Feb 2019, for which she was operated and biopsy was taken and diagnosis was confirmed. Then she was again going to underwent to the abdominal wall hematoma drainage in June 2019. In September 2019, she presented with 26 weeks of pregnancy and recurrent abdominal mass. Then in Feb 2020, she underwent a cesarean section along with mental biopsy. Then she was planned for a chemotherapy for the residual disease. Then she completed a 6 cycle of chemotherapy with the vincristine, adrimycin, and cisplatin, and 1 cycle of ibuprofen and etoposide. Then she again underwent to the for surgery for wide local excision and mass abdominoplasty in October 2020. Then she received a post-operatively 6 cycle of chemotherapy and 1 cycle IE. Then she admitted. Now she is admitted in a hospital with the complaints of abdominal distension and respiratory distress. On examination, patient is conscious oriented. The BP was 130/72. The pulse rate 91 per minute. SpO2 93 at room air, and respiratory rate was 26 to around 30. And in a local examination, abdomen was grossly distended. Midline surgical scar mark present. Fluid thrill was present, and rest other systemic examination was within the normal limits. Next, then the treatment and significant investigations are: treatment given in the hospital, that is the ascitic tap was done, after which she relieved with the respiratory symptoms. The 2 units of PRBCs were transfused for the anemia. Tap PCM 500 mg 8 hourly, tap diclofenac 100 mg as a sustained release BD, and tap morphine 10 mg 4 hourly and 20 mg in night, with and serum cremafine 30 ml HS. Tab gabapentin 300 mg 12 hourly, tab cyclophosphamide 50 mg 24 hourly, and pain with this dose of morphine, the pain was controlled, and NRS was 2/10. The PET scan on 11th of December 2021 show that metabolic active lesions arise from uterus with extension infiltrations, pelvic lymph node, peritoneal deposits, subhepatic deposits, and gross ascites was present. The investigation at the time of admission was the hemoglobin. The hemoglobin was 5, and TLC count, total leukocyte count was 12,400, and platelet 2,96,000. After which we transfused the 2 units of PRBCs. Then hemoglobin was increases, and on the 26th of December, the hemoglobin 9.7 and counts was 13,940. And as we see that the patient have a albumin is 2.5. So I'm next. Then psychosocial aspects. As a patient, she is a 24-year-old married female with 1 year and 11-month-old baby. She is concerning about care and well-being of her baby after her. Her husband is a private contractor by occupation and family financially weak. The caregiver is worried about the financial aspect of treatment, his own job, as he is currently severely restrained by the burden of disease, and he is also worried about his own health in the current COVID pandemic scenario, as he has to come hospital regularly for the follow-up, and sometimes come to the hospital with in some emergency situations like in severe respiratory distress. The main concern is the recurrent abdominal distension, which is occurred due to by the ascites, financial problem, and unwilling to come hospital in COVID period. Now the summary: that's a 24-year-old female suffering from the current peanuts in advanced stage, admitted in hospital for the recurrent ascites and respiratory distress. So main discussion point was is that can patient be manageable at home at this advanced stage of disease? How can we manage her symptoms at home? Like how can we go for the ascitic tap at the home? How can be address the psychosocial concern of the caregiver, like the patient need for the end of life care, and what can be done for this patient and her family to increase the quality of life. And this patient was expired on last weekend, 14th of Jan. So I just want to know what can I do at that time when I met that patient and patient caregiver.
Thank you, Dr. Mohit, for bringing in that presentation.
Packet ek doodh le aaogi?
So shall we start discussion, ma'am?
Yes, of course, sir.
Okay, so the first question would be, can the patient be manageable at home at this advanced stage of the disease? So, Dr. Mohit, can you please go back to the medications that you are giving for this patient?
Yes, sir. Yes, sir. Next slide.
Previous slide. Sorry.
Previous slide. One more. Yes, ma'am.
Yeah. So I think, see, apart from the transfusion that you have already done,
Yes,
all
sir.
the other drugs were oral, right? All the other drugs were oral.
Yes,
So
sir.
as far as the medications are concerned, so there is nothing that that should not be given at home, right?
Yes.
Were you giving IV fluids for her?
No, sir. No IV.
Because yeah, especially it can be counterproductive because of the gross ascites, and
Yes,
also there is low albumin. So
yes,
as
sir.
far as the medications are concerned, there is nothing that cannot be provided in the home that you are giving in the hospital, and educating the patient and
Actually, my main concern is that how will you improve that respiratory distress just because of the ascitic abdominal distension, which are due to the ascitic gross ascites. So how can we go for that ascitic tap regularly on the home at the home?
Definitely. So see, one thing. So I just wanted to clarify whether the respiratory distress was caused by ascites alone, or was there some associated pleural effusion?
No, it's just because of abdominal distension. There is no pleural effusion.
So there was no pleural effusion. So basically, it will be because of the ascites, especially when lying down, pushing the diaphragm up and causing the respiratory difficulties. So as you mentioned, so about ascitic tapping, right? See, the thing is, there are two types of ascites, as you already know. There can be a transudate and exudate, right? So in malignancy, usually it is transudate because there is leaking. So it is a low sag ascites because there is not much difference between ascitic fluid and serum albumin. So in such cases, the problem with tapping is whenever you are tapping it, you are actually taking some of the protein along with it. So because it has protein content because it's an exudate, so it can actually worsen the ascites if you are not supplementing protein. But especially in this patient, the albumin is a little bit low, so there can be some translative element to the ascites as well. But having the ascitic tap over and over again, whether it is beneficial is the second question. So we usually don't do ascitic tapping unless the patient is very symptomatic, when there is a gross ascites, and even if we do, we only take out 1 to 2 liters of fluid, not more than that, just to make the patient comfortable. So recurrent tappings can actually there can be some associated problems. So there may be risk of peritonitis, infection, recurrent pain, and how long will you go with this is another question. So in a terminal patient, repeated tappings may be counterproductive. It may not be beneficial as well because the fluid may accumulate faster. The second option to consider would be diuretics, giving a low dose of, giving diuretics. So that again, especially helpful only in transudative ascites. So if it is an exudative ascites, giving diuretics may not be much beneficial. So in this case, since the albumin is low, diuretics can have some effect. So for this patient, what I would recommend is, so we don't need to actually do ascitic tappings regularly. So even when we do tapping, so what we can do is take a minimal amount of fluid. And see, the thing is, finally, where did the patient end up dying, in the hospital or at home?
Did the patient die at home?
Home. So that is actually, so what did the patient want? So what did she want her final days to be?
Actually, she want to be that he want to be stay at home and the last time she.
Yeah. So see, the thing is, in this case, we'll have to actually weigh the risk and benefits, right? So if the patient really wants to be at home, so you know that the patient is terminal and she is going to die soon. If the patient wants to be at home and she wants to be with her family and the comfort of the home, so we should actually respect that wish. So we'll have to weigh that with the benefit that we will get from repeated tappings. So it is true that repeated tappings cannot be possible at home. So there are multiple risks for that. And in hospital, we should actually consider the risk of hospital acquired infections and all those things, and we are keeping there against the patient wishes. So there is no perfect option here. So there has to be some downsides and some upsides. So in this scenario, we'll have to weigh the risk and benefits. So I mean the upsides and downsides. Talk to the patient and counsel regarding the advantages of staying in a hospital and then going at home. So most usually the thing is, even if we don't have anything to do in the hospital, the patient's main inhibition is, so they will feel secure when somebody is around, doctors and nurses around, even though we are not doing anything, we're just going and seeing them. So just educating them that we can actually give all those things at home, and we can obviously try some diuretics to bring the fluid down, because especially since albumin is 2.5. So one thing, if they can be very, they are affording, and we are only expecting like a few days of survival, and before sending the patient home, one option to consider only in affordable patient is you can do a paracentesis and give her some albumin.
Okay.
If they can afford. So that will actually keep the fluid there for some time. So that the period of relief may be a little bit longer. So that is not routinely recommended, only in patients that you can that they can afford. And this is not at all a recommendation. Please keep in mind, we are not recommending albumin at all in dying patients. But if the patient wants to be at home and the ascites is very severe and she wants to be comfortable at any cost, this is something that we can discuss with the patient. One last ditch option that we can consider.
And then how will we go for that that psychosocial concern, that who will be take care of her baby after her? How can we counseling her?
True. See, the problem is we can only talk to the patient. So the question you asked, who can take care of the patient after that, is something that I cannot answer, because somebody else in the family, the father or somebody else, have to take care. But the thing is, we can actually talk to the patient, and the problem with that thing is, as far as the patient is concerned, she will have a fear. She will have a fear about the future of the baby. So since she's very young, she has a very young baby. So we can do is we can actually counsel, talk to the patient repeatedly, and have a family meeting, and just make sure that the baby will be taken care of even after her demise, and all those things. So it is quite difficult, but and again, it is not something that a single person can do. In this kind of situations, a like a multidisciplinary team is really helpful, a psychologist and all those things. And relating to that patient's so bereavement, actually, even after death care is one important thing in palliative care. So the patient's husband has some concerns about his employment and all those things. So if you have a social worker who can actually help them with the employment after that, help him in finding a job. So all those things. See, if somebody has actually talked to some of the local people, and the husband has a job, the patient can actually have peace. Oh, so even after I am gone, so he has a stable income, the baby will be taken care of. So all those things can be considered. So there is no single answer to this. So repeated sessions with the patient and including a multidisciplinary team, all those things will be beneficial in this case. So basically, it is reaffirming the patient. So the idea, the fear about the future of the baby, we can actually talk to her and reassure her that baby will be taken care of even after her death. So did the patient know that actually she was going to die, or it was actually kept?
She's no very.
So there was no collusion. So the patient was actually aware of the disease flow.
That's why she is more worried about that who will take care after her.
Definitely. So see, and one more thing I previously mentioned about home care, right? So whenever we discharge patients for home care, one major concern the relatives has, who will care I don't know to give medicine. I don't know how to take care of the patients. So before discharging the patients in such cases, you actually identify the primary caregiver at home and help them nurse the patient along with your trained nurses for 3 or 4 days. Let them assist the nurses in their care, in the patient's care. So by doing that again and again, the patient's relative will become more confident, so that these things can be. So these are not very difficult things to do, right? So once they do it along with the nurse, they will become more confident and of taking care of the patient at home. And psychosocial care, as I mentioned, it has to be a multidisciplinary team, multiple sessions. All ways of help would be beneficial. A medical, social worker, psychologist, all those things.
And then one more question, that how can counsel her husband that he always worried about that is a COVID pandemic and we have to become hospital again and again. I don't want to become again and again. If that patient can also get infected, or myself can also get infected. So he's more about concern about that his health and that COVID infection too.
So this is one thing where home care again comes into play. So if you can actually teach them how to take care of the patient at home and giving multiple nursing care education and options of treating the patient at home, he'll feel more confident. So it actually reduces the number of hospital visits required. And if there is an option of home visits that we usually have in Kerala and in many other departments, so there may be a local community that may be helpful for the patient. There may be a local palliative care team, or even from your hospital, if there is a home visit facility, a patient or a nurse, sorry, a doctor or a nurse can visit the patient periodically and check his status and all those things. All these things can actually help with the further management.
But all those things are not available.
No, definitely. I understand. It may not be available always. So you can, one thing you can actually help is there may be some organizations who are nearby the patient's village, some volunteers who may be able to help, whom you can actually educate, and you can act as a link between yourself and the patient, all those things. So education is the most important thing, home care education, and make use of all services available. That's the thing. So the third question would be, does this patient need end-of-life care, right?
Yes, sir.
Yeah, so the thing is actually end-of-life care will be another session for you. So I discussed it prior to the presentation, but again, I'll just touch up on this topic. So basically that end-of-life definition actually varies from side to side. So the UK medical definition says that it is actually the patient is likely to live for 12 months. So that is as long as a period that we define end-of-life care. So that will include patients who are actually having imminent death, incurable progressive disease, or a patient who is expected to have a life-threatening complication during the course of the disease. Also, all this can come in the broad category of end-of-life care. So you will actually talking about a patient who is actually nearing death, right? I mean, a patient who is probably going to die in days or weeks. So in that case, so basically in all palliative care symptom management, so we usually aims for a balance between symptom relief and function. So if a patient has some pain, so it is not our aim to completely sedate the patient so that the patient is pain-free. So it is not our aim. So our aim would be to find a balance between pain relief and function so that the patient can be as pain-free as possible while remaining as functional as possible. So obviously towards the end of life care, I mean, end of life where the patient is completely bedridden and the patient is going to die soon, our priority changes towards symptom management. So we can, there is no, rather than making the patient more trying to make the patient more functional, we will be actually concerned more about making the patient symptom free. So in that case, we can usually, there is something called a terminal sedation. When the patient is very restless and terminal, we can actually sedate the patient continuously. So end of life care, yes, because the thing is, it's a broad thing, and the definition says that 12 months. So definitely an imminent death would be end of life care. And basically there is no specific principle that we follow for end of life care. So the drugs are all the same, the principles are all the same. The only thing is when the patient is actually ambulant and active, so our aim would be to find a balance between function and symptom relief. And when the patient is terminal, severe breathlessness and all those things, our main concern would be symptom relief. So our bias changes towards that. So I mean, Sri Priya ma'am has just put up a message asking the spouse to give her assurance about the future of their kid also. Definitely. That's a very valid point. So that she'll be. See, the last question, what can be done for this patient and her family to increase quality of life? So in this case, Dr. Mohit, can you, ma'am, can you please go back to that medication slide? So I just wanted to tell some points regarding the medications.
Medication.
Yeah, please, ma'am.
Mr. Vaishnav, actually, he was handling the slide because I have some
technical
issue with the lab.
You want me to share the slide screen? I have a slide.
No, sir, no worries.
Yeah, sure. No, it is towards the beginning, I think.
Just
no problem. Yeah, same thing. See, Dr. Mohit, I just wanted to point out a few things. So basically, improving the quality of care of the quality of life of the patient would be improving the symptom relief as well, right? So the thing is, see, one thing I wanted to point out first is morphine obviously is a good choice. The patient is having less pain relief. The first thing I wanted to point out, because our session was related to constipation and bowel obstruction. Syrup crimafin was your laxative of choice, right?
Yes, sir.
So in morphine, it should be a contact or stimulant laxative, not just crimafin. So there is a formulation called crimafin plus. So crimafin is actually liquid paraffin and magnesium sulfate, I think. So both they are one is a stool softener, like a lubricant, another is an osmotic laxative. So basically it will actually increase the fluid secretion and make the stool soft. But morphine typically produces constipation by acting in the intestinal opioid receptors and decreasing the peristalsis. So in that case, a stimulant laxative like sodium picosulfate, which is the component of crimafin plus, and or bisacodyl, most commonly used, should be given. So see, obviously, if the patient is constipated, obviously their quality of life would be less. Second thing I wanted to point out that tablet paracetamol 500 milligram 8th hourly. Were you giving it for fever or for pain?
Just for pain, multi.
Yeah. So for pain, paracetamol 500 milligram is actually an inadequate dose. It should be at least 650 milligram to 1 gram. 650 milligram to 1 gram. We usually give 1 gram. So you can actually increase the paracetamol to 1 gram 8th hourly. But pain was controlled. But again, paracetamol 500 milligram is not an analgesic dose. Another thing would be diclofenac, NSAIDs. So you told that she was having an HB of 5, I remember, right? When she came in. So why did she have anemia? Did she have a bleeding or something, or it is because of the disease?
I think, sir, it's just because of that nutritional deficiency, or because patient was not that too much able to eat something. Yeah, and especially she had a hematoma before, so I was just wondering if there is any bleeding. So in that case, see, long-term use of NSAIDs is not usually beneficial, because NSAIDs along with abdominal distension can cause some gastric ulceration, gastritis, and also it can cause bleeding because it can cause platelet dysfunction. So if you actually use it for long term, diclofenac is relatively less usually doesn't cause platelet dysfunction as compared to the other COX-1 selective, non-selective COX inhibitors. Diclofenac is more COX-2 selective. It doesn't usually cause platelet dysfunction, but again, if there is bleeding and some gastric symptoms, it is better to avoid diclofenac. So the third thing, now what was the indication of gabapentin? Actually, see something saying that numbness or that tingling sensation. That's why we started that gabapentin.
Definitely. So if there is neuropathic pain, definitely gabapentin is indicated. Another thing would be cyclophosphamide. See, the thing is WAC regime, right? So are there any practicing medical oncologists in this group? So basically, according to my understanding,
no medical,
no. According to my understanding, WAC regime, the C stands for cyclophosphamide.
Yes.
So it is given in quite a high dose. So you have said that even after WAC-IE, the patient has actually progressive disease. So she has already been exposed to cyclophosphamide and disease has progressed. So this is a metronomic chemotherapy. You are giving cyclophosphamide continuously 50 milligram. So if the patient is terminal and she is already exposed to cyclophosphamide and the disease progressed while on a much higher dose of cyclophosphamide, so there is no point in giving cyclophosphamide again, especially in this terminal stage. So cyclophosphamide.
That cyclophosphamide, it was started by that our surgeon, that oncosurgeon, that we can go for any. If we cannot give that proper chemotherapy, we can start that cyclophosphamide orally to relieve some symptoms.
Definitely. So metronomic chemotherapy as a maintenance definitely give, but again, my points would be, one, the patient is terminal, so you are not expecting any change in the oncological disease status as far as the patient is concerned, because she is going to die in weeks or days, right? So tablet cyclophosphamide 50 mg is not going to change the tumor drastically to make any difference. And again, this patient was already exposed to cyclophosphamide at a much higher dose than the main chemotherapy. So the disease progressed in cyclophosphamide. So such cases, again, the chemotherapy drugs can actually cause gastritis, nausea, vomiting, and all those things, which may add to the symptom burden of this patient. So in such cases, at least when the patient is terminal and we are not expecting a relief to the patient, this thing can be avoided. So all these things actually can improve the quality of life of the patient. So as far as quality of life of the family is concerned, again, as Sri Priyam also pointed out, reassuring the patient and seeking more avenues of support regarding the employment and all those things could be beneficial. So bereavement care is important. So even after the patient dies, so if somebody can follow up with the family and give them continued support even after the death of the patient. See, palliative care doesn't end with the patient. So it actually takes into account the family also. Even after the patient dies, we should offer continued support to the patient's family so that actually they are able to tide over that difficult phase by all sorts of support. So a social worker can help with it, a psychologist can help, continuous talking sessions, follow up, phone calls, all those things can be definitely beneficial.
Okay.
Thank you, Dr. Mohit.
Thank you.
Any other inputs from the participants where you feel that, of course, we are sorry to know that the patient is no more, even not at all, we don't know the patient as a person, but still thinking about that 11-month-old baby is what makes me personally attached to that particular case. So anyone would like to put their inputs, like how we could have done something better in this case, or what would you have done, or you might be having some experience of your own intersections.
Ma'am, I would like to say something.
Sure, ma'am.
Like since I have been working in ICU for so long, I feel that when we know that the patient is at the terminal stage, some sort of a spiritual teaching so that the patient can be detached from the worldly things also helps sometimes, as per his or her own religious beliefs. That helps to alleviate pain also at times, and the patient passes away perhaps more contented. So if those sorts of practices can be incorporated, I think it would be very beneficial, and especially in the younger patients, because they are more attached to their families and everything, because it is almost like, in this case, it is almost the beginning of life where life suddenly ends. So otherwise it becomes very traumatic for a person who is lying in the bed and continuously waiting for death. So
that is actually a very valid point. So I think when in the pain session, you must all be aware about the total pain concept, right? So you must have all heard about the total pain concept. So it basically was put forward by Dame Cicely Saunders, who was the founder of palliative care. So she says that the pain experience consists of physical pain, psychological, spiritual, emotional, social, all those aspects. So spiritual aspect is definitely a cause of distress, especially as ma'am rightly pointed out. So young patient can actually question, so why did God do this to me? So what wrong have I done? So I've just had a baby, I was just starting. So these things can definitely actually cause to distress. So I mean, religious beliefs can vary from person to person. Some people may be atheistic, so I'm not commenting on that, but definitely. And one thing you should all keep in mind is spirituality is not only religion. So religion is only a part of spirituality. Spirituality is basically how, I mean, I would like to think as how you actually identify yourselves, or how you actually connect to your surrounding world is spirituality. So religion is a part of it, but it is not always religion. But definitely, if the patient is a believer, a religious person, definitely a religious person can help, and religious counseling can help. But again, spirituality is a very important point. So that, thank you for bringing that up. So in managing distress, spirituality definitely is a spiritual, emotional, all those things should be considered in the psychosocial care. Very good point.
Very true, Dr. Shekhar. Like if a person is getting a confidence or a hope that there is something over and above the human power which is going to support her and her family once she is gone, maybe that will help to reduce her stress up to some extent. Anyone else would like to share? Yes.
Hello?
Yes, Dr. Sanjana, please continue.
Hello. Yeah. I'm sure it's I wanted to share is
Dr. Sanjana, I believe there is a network
this
issue.
patient of pregnancy, she had actually had hello, am I audible?
Now audible.
So this is not about the patient, but one thing I noticed from this case is that she had been diagnosed before her pregnancy, and she was diagnosed with this left adnexal mass and and which I should be unsupervised happened. And personally, I think not for this contraception and all those things. This is when even with the patients who are supposedly, we know they would have a difficult pregnancy and all those health complications will come, but still nobody really talks about how to prevent pregnancy or how to, that contraceptive part is not very well discussed in our in our
Dr. Sanjana, extremely sorry, but we are losing you in between.
So basically, I mean, what I feel that what Dr. Sanjana was mentioning, since she was, sorry. Please continue, Dr. Sanjana. Since she was diagnosed even before her pregnancy, she could have been given the option of a contraceptive.
okay,
Definitely. That's an option.
Yes,
See, the thing is actually,
I think
one thing I wanted to point out is that is a very good option. So that is something that I would have personally gone for some of my relatives. I just have to confess that. But the thing is, there is a widespread stigma towards abortion and all those things in our society. And in many cases, this decision of an abortion, if the patient is already pregnant, is not her alone. See, sacrificing one's life for her child is seen as an act of sacrifice or bravery. That is, see, I don't believe in that. See, the option of abortion would be something that I would have done for some of, if it was my relative or my wife, definitely, no question about that. But having said that, in our social setup, so there is actually a widespread stigma about abortion, and I have seen people who are actually wholeheartedly willing to sacrifice their life to give birth to a baby. So definitely, this is one option that actually you can.
Yes, sir, that I really understand the sentiments that people have about
definitely
having the baby. What I am saying is that I have seen many patients who is having, maybe the SLE, like SLE patients, and patients who are having hematological disorders. And usually what happens is the doctor sitting, they will be prescribing the drugs they have to take, but they don't usually comment about taking the contraception to the females. Somehow it is perceived as it's not our idea. Okay, they usually don't talk about it. Because I personally have seen a patient who is having I think she was having a bleeding disorder. She already had one baby, and she was taking Vislon and all those things. Not Vislon. She was having warfarin. She's on warfarin. So when I saw her, I asked her, "Are you on any kind of contraceptive measures?" And she was shocked, and she didn't wanted to have that conversation because of the stigma. The thing is that people don't open up that conversation. She could go for an intrauterine and have a very safe. She could be safe with her health, and also if she's on warfarin and having a baby. Is
valid
higher
point,
chance
Dr.
of having.
I think we are losing you.
This is a conversation that we have to talk. Okay, sir.
Definitely, yeah, exactly. So see, this contraception, the problem is that what we are doing is we are actually becoming very tunnel vision, because we are actually only worried about the disease, and we fail to foresee the social, emotional, and all those aspects there. So see, the concept of palliative care would be to see the patient as a whole, to see all the sides, social, emotional, all those things. So in such cases, we'll have to foresee the social consequences of having a pregnancy with such a disease. It should be definitely considered. So before actually ending the session, I just wanted to answer one question. So Dr. Krishnapriya has asked, recurrent ascites with mechanical distension, very distancing. The method mentioned is usually not enough for control. Any specific counseling? Or see, I totally agree. I totally agree that, so whatever I have discussed, so whatever palliative care textbooks will tell you is not actually enough to completely resolve the ascites. It's very distressing. So we are actually only trying to reduce the discomfort. See, the problem with malignant ascites is as long as the tumor is there, the secretions will keep on coming. It's an exudative ascites. So the ascites will keep on coming. The more you tap, the more protein you will lose. Again, the ascites will again build up. See, if you ask me, the only permanent way to take away ascites from such patients would be to have like a continuous ascitic drainage with a catheter. But that is not that we usually do. That is what I have to agree that this is not something. It's not a scenario where we can actually make the patient absolutely comfortable. We can only do the best possible that we can do, and as comfortable as possible, as we always say, as comfortable as possible within the limitation. It's very distressing. I totally understand. See, the only logical way to completely resolve the patient of ascites is to keep on draining it with a continuous drainage system, because as the fluid accumulates, it will go out to the catheter. But again, that is not that we usually do, because it has some other problems, infections and all those. So other than that, there is no way to completely control the ascites. We can only tap when it is very severe. We can try some diuretics, we can cite some position changes and all those things. We can offer a high protein diet, not very beneficial, but if the albumin is low, we can do that. All those things can be done, but I agree that this is not a foolproof way of treating malignant ascites. Definitely, see, after all these things, people can still be having a significant distress. So definitely. That's actually a very valid point. So before concluding, one more thing, I'm just taking 1 more minute, Priya ma'am. See, the thing is, in palliative care, we whatever be the symptom, absolute analgesia or absolute symptom relief is rarely our aim, because it's rarely possible. So even if we give high, huge doses of morphine, the pain may not be controlled. See, we are actually aiming for adequate pain relief. And I agree that even with all these measures, patient may be in significant distress. So see, all those things, we will try our best. That's all that we can do, right? So malignant ascites is not something that we can treat very easily. As long as the tumor is there, secretions will come up. Definitely, it's a very distressing condition. These things will help. That's all we are telling. And the only option would be to have a continuous peritoneal drainage. So the problem with all those things is the tumor can deposit in that opening site. It can have a new growth there. All those things can happen. So there can be infections and all those things. See, the thing is, I have seen patients with peritoneal carcinomatosis. Whenever we tap, so the site we tap, after some time, a new nodule will form there. The cancer cells will track to the tracking, and the new growth will form. All those things are there. So yeah, it is a very difficult condition. So we can only try our best.
Thank you. Sorry about that. Thank you, Dr. Jewell, for your time. I believe that as Dr. Shweta correctly mentioned, this was a very informative and stimulating session. We do completely agree to that. And just reminding that, of course, each and every human being who comes in front of us, whether we be medical professionals, non-medical professionals, is always a new learning, and the entire life is a process of learning, unlearning, and relearning. Just reminding that with that note, and hoping that all our sessions become a fresh experience of learning to each and everyone out there. This is Sripriya along with Dr. Jewell Joseph and Mr. Vaishnav signing off from the Tips Echo Hub. See you the next session with another faculty and another interesting session. Till then, everyone, please do take care. Stay safe, stay healthy. Bye-bye. And please don't forget to leave the feedback. Thank you, everyone. Bye-bye.